Hello, my name is Brian Dierckman. I'm an orthopedic surgeon at Elite Orthopedics. I'm a sports medicine and hip specialist. As far as sports medicine goes, I predominantly do surgery of the hip and the knee for joint preservation procedures. I do also do shoulder surgery as well. Having said that, I also specialize in hip comprehensive surgery, including hip replacements, periacetabular osteotomies, and labral repairs and labral reconstructions. I did a residency in orthopedics and wanted to be a sports medicine specialist, and I did a sports medicine fellowship. During my sports medicine fellowship, I had hip problems myself. Ended up having both of my hips scoped at the same time. Unfortunately, I had a bad outcome and I wanted to figure out why. And so I started doing a lot of homework and research on more complicated hip problems, and it led me down a path of doing a whole second traveling hip fellowship and dedicating a large part of my career to hip surgery to kind of help save other people's hips. As far as hip injuries goes, the more of the common ones are labral tears are probably the most common ones that I see in an active population. We also see hamstring injuries are pretty common, as well as other rare little things around the hip like abductor tears. But again, labral tears are the most common significant problem. I mean, there's a lot of tendinitises and things like that that respond to non-surgical measures, but as far as surgery side, I think labral tears is by far the most common until you get into the arthritis category, where then we're talking about hip replacement. Understanding what causes hip problems to begin with is step one, and so I think a lot of repetitive deep flexion activity causes a lot of hip problems, and so prolonged sitting can cause that, as well as a lot of twisting and turning and pivoting activities. And so there are other activities that are better for your hip, including elliptical typically, and stationary bike or on a recumbent bike, and not doing such deep squats or deep lunges, or all kind of avoid putting the hip at an at-risk position. The next thing patients can do is really focus on strengthening their hips. I think that very few people do, when they do core, they don't think that core should include their hips, but it does, specifically their gluteus and medius and minimus tendons. And typically that's best done through doing bridges and other kinds of other activities that can help stabilize and strengthen your pelvis and your core. Labral tear in the hip, to back up then, a labrum serves as a gasket or a seal. And so it's a fibrocartilaginous ring that sits on the rim of the cup. And so you picture it as like a ball in a socket. The labrum sits on the rim of that cup and holds the ball in the socket. And it truly is like a suction fit seal. And so the labrum is densely innervated with nerve endings. And that's why they hurt when you tear them, is because it's very protective to the joint. And so once you start getting labral tears, it's a precursor to more damage in your joint and eventual arthritis. As far as the labral tears go, that's why we fix them, is they're so crucial to the function and stability of the hip joint. As far as fixing them, then we go in arthroscopically, typically through poke hole surgery, and we go in and we stitch them back together down to the bone. Most people, however, can avoid surgery through conservative measures, including therapy and activity modifications and anti-inflammatories and other types of injections as well. As far as labral tear recovery, most people in my practice, are on crutches for 2 weeks. The first week they're foot flat weight bearing. The second week their weight bearing is tolerated. And at the end of the second week, I tell them to start trying to walk at least down to one crutch or wean off crutches completely for a standard labral repair. By 6 weeks out, they're back at the gym doing low-level activities, and at 3 months out, they get cleared to start a walk-jog program. And then most people by 5 to 6 months out get cleared to return to pivoting and turning and kind of higher-level activity sports. Unfortunately, some labral repairs fail, and some labral tears are not fixable. More recently, several surgeons have developed a technique of a labral reconstruction which means we make an entire new labrum for you out of cadaver tissue. We do that all arthroscopically. It's through more poke holes than a typical standard repair, but it's still a very minimally invasive procedure where we again go in and we put in a whole new labrum, and which is very important to restore again the function and stability of the hip joint. The recovery is a much longer recovery, but the success rates are very, very good, actually up into the 80 to 90% range for success. And so it's a very good salvage procedure. Having said that, most surgeons don't recommend doing a primary labral reconstruction. They typically recommend you try doing a labral repair first. I think it makes sense that trying to get your own tissue to heal is better than putting cadaver tissue in there trying to get an entire new labrum to heal down. There's not very many people within the whole United States who do that. Thankfully and fortunately, I've had the ability to learn how to do that from some of the leaders in our field. And I do now travel around the country teaching this to other surgeons as well. It's a very complicated surgery, like I said, and so there's very few people around the country that are skilled and trained in doing so. I had the opportunity to train from one of the top surgeons in the US, and also had time to go overseas to Switzerland and train from the world leaders in the procedure. And so I have learned how to do that procedure, and I look forward to helping people who need it with fixing their hips. This is what I had. I mentioned that earlier, but I ended up having dysplasia in both of my hips as well. It was unrecognized, and that's why my hips failed so rapidly after my surgery. And so I had the wrong surgery, frankly, and it had devastating results on my hips. And so you can see the importance of getting the correct diagnosis and the correct procedure. Another condition that is relatively uncommon in the hip is something called hip dysplasia. Hip dysplasia is a condition where the bone that covers the ball, the roof, so to speak, instead of it fully covering the ball, it's a very shallow socket. And so biomechanically, the hip is at risk because it doesn't distribute the load evenly across the roof. And so you essentially get overload on the rim of the cup, and you get labral tearing and chondral failure, right? Damage to the cartilage. And that's how you get early arthritis. And so several surgeons all around the world developed a technique called periacetabular osteotomy, which is commonly known as PAO, right? Where we go in and you actually make an incision in the front of the pelvis, and you create 4 cuts in the pelvis. And essentially, the roof is then free, and then you can move the roof over the ball and kind of cover the ball, and you go in and put screws in to hold those bony cuts that you made back together. It's a big surgery. It is a risky surgery, but it's a very good surgery. When it works really well. Hip dysplasia, as far as what we typically treat, is something that comes on more during the kind of late childhood or early teen years or adults. And it's different from the childhood form. There's a congenital form that babies get, and this is different than that. We don't understand fully all the risk factors and causes of dysplasia. There's some genetic component. Either way, it presents with pain in the hip, obviously, typically worse with standing and walking pain. And it's not usually something that hurts when you're sitting or laying down. It's usually something when you're standing and you're walking. And so when you're active, people notice that they feel a pain deep inside their hip, or they feel pain kind of on the outside or front of their hip. As far as PAO recovery goes, you're typically in the hospital for several days. You're on crutches for the first 8 weeks typically. The first 4 to 6 weeks, you're foot flat weight bearing or protected weight bearing, and then after that, it's progressive weight bearing. Most people by 8 to 10 weeks out are weaning down to a cane, and usually by 3 months out should be able to walk without a device. After that, it's all strengthening and stabilizing the hip and the pelvis. And usually by 6 to 9 months out, most people are back to resuming high-level activities. And by a year out, you're back to playing high-level sports at your previous level. Once the hip has progressed to the point of having arthritis, what I tell my patients is that it's a one-direction disease, and they understand that it's only getting worse, and so you can't reverse arthritis. So then it's all about symptom management until everything else has failed and you're ready for a hip replacement. So as far as symptom management goes, there are a lot of things you can do. The common things that I tell my patients are activity modifications, right? Low impact activity is better, like stationary bike and elliptical. Doing anti-inflammatories like Advil or Aleve and things like that can help. Once those things fail, you can try more formal things like physical therapy to build strength, to stabilize the muscles around the hip, to unload and protect the damaged hip. After that, you can do more aggressive things like injections of cortisone or PRP and things like that to kind of give you pain relief. Having said that, none of them fix the hip joint. And again, it's all band-aiding or making the symptoms go away or minimize the symptoms. Eventually all that fails and then you need a hip replacement. I do the anterior approach hip replacement. I believe in that because I think, and data does show that it's a faster, easier recovery on the patient side. And once you go through your learning curve and you've done a lot of these, it's actually a faster, easier procedure, and it's more accurate with leg length and also for stability. The traditional approach is the posterior or posterior lateral approach. That's the most common procedure done, but again, anterior is gaining favor because of this dramatic increase in recovery, especially during the first 3 months. I think that if you look at the data critically, that most people would argue by 3 months out, there's really no difference in outcomes, but during the first 3 months, anterior approach is definitely a faster, easier recovery for patients. Most people after a hip replacement are usually on a walker for 1 to 2 weeks and a cane for 1 to 2 weeks, and by a month out, they're starting to walk without a device. Usually by 6 to 8 weeks out, they're back to the gym starting to do low-level activity, and usually by 3 months out, they're starting to do all the things they used to do. Having said that, I don't recommend that people run and do higher level activities like that, but it's totally okay for them to do biking and hiking and low level sports like doubles tennis. I think are all things that you can eventually get back to. But again, I typically don't recommend running just because it can wear the parts out quicker. Thankfully, football is typically pretty benign as far as hip injuries go. You can get a lot of tendon injuries around the hip, all of which you typically heal and recover very quickly. Having said that, some can be more significant. We did talk about labral tears, and so labral tears can happen in the hip. Most of those are usually traumatic in nature from getting an awkward position or getting hit awkwardly in the pile. I think famously Tua Tagovailoa, he had a fractured dislocation of his hip. That can happen when somebody lands on you awkwardly in the hip, and that can be a devastating injury, but thankfully that's very rare. And most injuries are benign around the hip joint, and they recover after icing, anti-inflammatories, and stretching, and some rest. People often ask me what activities that I think are best for the hip joint, and I think that if you look at the mechanics of the hip, something that has lower impact, so running I don't think is great for the hip, and so I'd rather have people walk on flat surfaces. I don't think walking is great, however, because it's prolonged impact as well, and it loads the hip. And so typically, I think better would be biking, is what a lot of people would say is one of the best exercises. If you're going to bike, it's typically more of a recumbent or an upright position. Bending or leaning forward is not ideal. As far as other activities, then elliptical is also a great activity, and then hiking is also a good activity to build hip strength and protect your hip. We hope you found this helpful. Again, my name is Brian Dierckman. I'm one of the sports medicine specialists here at Elite, specializing in the hip as well as the knee and the shoulder. Check out our webpage at eliteorthopedic.com for more information about the shoulder, hip, and the knee.